Good afternoon, dear ladies and gentlemen. A wonderful welcome from the city of Vienna. It's the 4th September 2025 and we're here at the 9th OSSEO, hosted by Professor Georg Sprinzl and Professor Astrid Magele. It's a wonderful meeting here. There are 650 live participants for these meetings, and now you're additionally online. So welcome to all the people here in the room, in the hall, and also at home for your laptop or in the office instead of working something. So where we are the hearing group, and I'm the honor to be General Secretary of this hearing group for some time. The hearing group was founded 2007 here in Vienna, and it's unbelievable. It's already 18 years that we have the hearing group. The hearing group is an association of 33 ENT departments now worldwide on all 5 continents, and those 33 departments work together now nearly 2 decades. We are medical doctors, surgeons, we are audiologists, therapists, speech therapists, teachers, technicians, physicians, inventors, all people who are dedicated to cochlear implants. You see here on the screen one of our last meetings in Dubai, led by Professor Hajra, and it was a very fruitful meeting. In this particular moment, we are now 36 centers, and for example, Vienna is one of these centers, as St. Pölten from Professor Sprinzl, or Würzburg in Germany, or Warsaw in Poland, or Antwerp in Belgium. We try to bring innovations through research. We are dedicated researchers. We try to educate people. Please look into the internet. If you just follow us, the very first line, look at YouTube to our hearing roundtables. We have now over 20 hearing roundtables, usually 90 to 100 minutes long. We have white books about different topics, how to found a cochlear implant center, what to do in audiology, how to find the right patient, how to do the right surgery. So we have now setting the standards since the year 2008. And now please be aware it's a hybrid and interactive meeting. So I can see what you tell us via the computer, which questions you tell us. You can raise the hand. We try to incorporate the questions into our round table, that it works. All the meeting will be recorded, so I hope that within 1-2 weeks this meeting will be available on YouTube too, as all the other meetings are available permanently on YouTube. And now it's my pleasure to introduce an unbelievable lineup. I start with Professor Arthur Castilho from the University of Campinas in Brazil, Professor Mario Cernotti from Cordoba, very important Austrian city, in Argentina. Professor Di Paolo Vernetta, he is from Valencia. Professor Georg Matthias Sprinzl, our host and president of this 9th OSSEO meeting from the Karl Landsteiner University in St. Pölten. And last but not least, Professor Javier Gavilan from the Hospital La Paz, University of Madrid. He will moderate. And now let's start the round table and let's fly to Madrid for the next session. So I hand over to Professor Gavilan. He is here in Vienna and he will moderate this round table. Please, Javier.
This is for them. Thank you. Well, thank you very much, Baumi. Well, the room is packed. It's great. So, hi everyone, and welcome to this, as Professor Baumgartner mentioned, hybrid hearing roundtable. We are in Vienna, in Austria, and we are at the OSSEO 2025. And today we have a special format of our roundtable program that started with the pandemic. At the beginning, it was just the only way to communicate, and after the pandemic, we've been doing the same, But right now we are incorporating live attendance. It's not only online, but this is going to be a hybrid activity with people both on the spot here in Vienna and people connected by video streaming. In addition, this roundtable, as all hearing roundtables, are recorded and can be reached in our webpage, as I will say at the end of the roundtable. Well, the topic today is a topic related to the OSSEO, is bone conduction implants around the world. And over the next 45 minutes, hour and a half, our panelists will share with us their expertise on the world of bone conduction and also active middle ear implants. At Hearing, we want these activities to be interactive. We want you to participate, and by you I mean those here in the room and those also at home. And to achieve this goal, during the discussion, we will give you the opportunity to participate here live, and we will ask you to use the chat of your Zoom connection for those of you at home. And using the chat, I will be able to see the questions you have, and I can put these questions into the panel. And to start with this interaction and demonstrate that I really want this to be interactive, I would like to ask you to switch on the cameras of your cell phones, both you here and those at home, and you will see in a minute a QR code on the screen. You will see a QR code. We need the QR code. The QR code is there, and you can scan this QR code, or you can also go to menti.com. You go to menti.com, and by using the code 544-06911, looks like an emergency, you can answer the first question we have here. So the question is, what is your field of expertise? You're a surgeon, you're ENT, you're speech therapist, audiologist, industry. So we have 70 people here, 72, 73 connected, 74 right now, and more than 30 answers right now. It's just to have an idea of who is the attendant, who are the attendants of this event. So as you see, they're mainly audiologists, otology, and audiologists. So between otologists and audiologists. Okay. Good. Let's move to the next question, and this will be the last question. And the last question is, we would like to know, where are we present right now? Which country are you from? Those here and those at home. Wow. UK. No, Argentina. Okay. Argentina. Well, I understand Argentinians were yesterday. They were the only, the most powerful attendants of the surgery. So the Argentina. So maybe we should shift to Spanish, and we do it in Spanish, Mario. Actually, it's three of us is speaking Spanish, and only one Portuguese and one German speaking. So anyway, we have Austria, Saudi Arabia, Argentina, Spain, and South Africa, Egypt, Germany, a lot of countries. Okay. So that was the introduction, and right now I think we can start with the real scientific part of the session. And this will be a session that we will have virtual traveling all over the world. So we'll visit different places, and I promise no jet lag will be here. And the first place we are traveling will be Cordoba in Argentina. this was a virtual trip, but this was a time trip. I mean, this is a time machine. We went back to the past, like 45 years ago. And we are here with the grandfather of the guy in the picture. Sorry, Mario, but you should change that picture. I mean, this is. It was when you did your first communion, so it's crazy. So the guy in the picture not, but the guy here on the table is Mario Cernotti, is the professor of otorhinolaryngology at the Catholic University of Cordoba and the otology clinic of the Speech Therapy School of Cordoba National University. He's also the director of the otorhinolaryngology course at the Sanatorio Allende and the National University of Cordoba in Argentina. Mario has more than 30 years of experience, so you can imagine this was not a real picture, in ear and hearing loss surgery. And the hearing group is really glad to have you as one of our distinguished members. Mario will deal today with a double issue. He will deal with bone conduction in children and long-term reliability. Mario?
Thank you. Well, I will talk in Spanish because Argentinian is most people. No, I will talk about the bone bridge in children. We have many evidence that the bone bridge in children is a very good tool, a very good device to improve the hearing in this population. And between the evidence, you can see that there is the first option in microtia atresia patients, very common in our region of South America, as you know. The other option, between brackets, it's a vibrant sandwich, but you know that our philosophy is keep it simple, but vibrant sandwich in some cases of oral atresia is a very good option to bone bridge. The second is that this is a fair option to treat the chronic otitis media. In our countries, in emerging nations, as Brazil or Argentina, it's very usual the presence of the chronic otitis media because the economical situation, the social situation is not the best. This is the main reason because in our countries, the chronic otitis media is very usual. We need to treat not only the infection, this is the first step, but the second one is to recover the hearing loss. Of course, this option is not the first. It's the second or the third option after the try to reconstruction, the famous second look, okay? To reconstruction using the PORP or a TORP, and with bad results, you can to think about the bone bridge. The surgery, as you know, is very easy. It's a fast surgery. The results are excellent, more in between 35 to 40 dB, the functional gain, and has the lowest rate of complication, as you can see during the morning in this Congress. But we are the unmet needs. The unmet needs is we need to open mind to recognize that we can do the bone bridge under 5 years old, because the possibility to do the surgery under 5 years old is very, very real. We had a publication 3 or 4 years ago talking about this. Is it possible from Georgis, an expert in the mal, 2 or 3 years old is enough to do the surgery, because we need to change the paradigm from the anatomy criteria from age criteria, because the limit is not the regulatory agency that said 5 years. What happened with a child with 4 years and 11 months? It's impossible. No, it's totally crazy. And the other is we need earliest stimulation, and of course, to decide, we need more reliability studies. Therefore, this is the anatomy criteria versus age criteria. You can see in this publication of our group the transcutaneous active bone conduction, bone bridge, implantation in children under 5 years old. It's about only 2 cases, but nowadays it's not 2 cases. They were the first 2 cases with 2 and 2.5 years old, because the anatomy criteria said that the mastoid is enough space to put the bone bridge. And at that moment, we use the 601, that is bigger than the 602. Therefore, it's very simple to put. You can see in this slide that the bone bridge is the oldest one. Second, we need early stimulation. This is a publication of our group together with the group of Professor Charaviglio, where we implanted 21 microtic atresia patients in pediatric age and reached the following results in word recognition test. 27 moved to 97. Finally, the reliability, you can see this paper finished 1 month ago, together with Professor Leonardo Ordóñez from Colombia. And you can see that this is the first study on long-term bone bridge survival rate. It's submitted to publish. We control 186 devices. The maximum follow-up reached 10 years, impossible to do to the other transcutaneous prostheses. And the major complication is less than 2%. The device cumulative survival rate reached 98.4%, and the device plus the medical survival rate reached 96.2%. Therefore, you can see in the pediatric population is exactly the same numbers. Thank you for your attention.
Thank you, Mario. Okay, so do you agree that children bone conduction devices is a matter of anatomy more than age? Carlos?
Yes, I completely agree. My indication is not the age, is the possibility to adapt the implant, in this case the bone bridge, in the school of the children.
You also do, Arthur, you also do children younger than 5 years of age?
Not very often, no. We have a restriction in this kind of Brazil because the product usually is registered above 5 years, but usually the patients come at the age of 5 or more.
Okay.
And also agree with him.
And what about Austria? You do it younger than 5?
Yes, so we did a case in a bilateral atresia. We do those cases. For unilateral atresia, I would be careful because there's no such a big need to intervene. But when you have a bilateral atresia case and the patient has the requirements to do the surgery, why you should stop?
So
technically, it's possible, and we have excellent outcomes with that.
Okay, how many of you are using bone conduction implants routinely? Okay, keep the hands up. How many do in children? Less than 5. Less than 5 years of age.
Don't lie.
Okay, so, and we are doing this because of regulations? I mean, we're scared of official regulations, or we just want to do over 5 years of age because we think that's right? Who wants to answer? In the room. Mario.
In my opinion, the problem is the insurance company, because the label said 5 years old. This is the reason, because we need to work to change this paradigm.
Okay. Yeah, no, there's any question? Yes, please. Because of legal issues related to doing something. So we should change regulation. How would you change regulations, Georg? You are.
Well, it's a difficult story. So first of all, of course, there's some legal issues, but on the other hand, there's also financial issues. I live in a perfect world, so we have full funds for whatever we want to do. And if you have a child with a bilateral atresia, and you have parents motivated to help the child, you can go for it. But we have, of course, the world is very different, yes, and we have other countries where we don't have so much funds, and then we are running into trouble to treat those patients in a proper way. I had a discussion yesterday where they're even in a country where they're failing to do unilateral atresias at the age of 5. Which concerns me as well. So they do first the plastic reconstruction and then the functional reconstruction afterwards. I think this is the wrong way which we are going in those countries. So we need to take care first of functional reconstruction and then later on aesthetic reconstruction in case of microtias.
Yeah,
my personal opinion.
Okay, one more question. Mario, you have experience on that. Do children need some kind of rehabilitation after bone conduction implants?
Yes, but it's not the same that the cochlear implant patient. Need rehabilitation, but it's different, completely different. But let me tell, the unilaterally, our atresia, it's a problem. And usually the colleagues consider that it's not very important because 1 year replace the other. No, yes. But it's not real. There are studies that demonstrate that 60% of the patients with unilateral atresia suffer from problems in the scouring.
Okay, Georg?
This is what I wanted to mention. So we try to do those cases with unilateral atresias before they come into the school or when they switch from the elementary school to the higher school. So that they have better support in difficult hearing situations, and they benefit from that. And honestly, those patients don't need to have a big rehab, so they're taking the device and using it.
And children with bilateral atresia, they do need bilateral bone conduction devices?
So we
Come on,
don't
say it. Who cares?
So we don't have so many cases. We did one case, I think, 3
yes,
years
but
ago.
these guys in Latin America, they have a lot of cases. So, Arthur, they need bilateral bone conduction devices?
If audiological is possible, yes, we have done bilateral in children with malformation. We have done quite some, yeah. And the good is that you don't need so much rehabilitation after that. It goes very easily, not compared with cochlear implants.
Mario, also bilateral in Argentina?
Yeah, we try, but it's not easy in our countries. But Arthur said bilateral is the ideal situation of hearing.
Okay, so one of the advantages of bone bridge is that it goes hidden on a bone bed, partially hidden on a bone bed. Is this real a real advantage, or that doesn't have any impact on the long-term results? I mean, it's not protected from trauma. Do you think this is a good thing for the implant, or it doesn't make any sense? Carlos.
We didn't have any problem. Usually, if we do a triangular muscle flap with an upper base, we didn't have any problem with the time in those.
But I mean, having the implant inside of the bone does make an advantage. It is an advantage.
We always try to put all the implant inside the bone.
Is there anyone who's not using a bone bed for the bone bridge? Just putting it directly on the bone? Okay. So, and something that I really like from bone bridge, if we are dealing with bone bridge, is that you can adapt it to the shape of the head. Do you think this is important in children, or this is not? I mean, this is just one more thing just for advertisement.
Yes, I guess it's good, especially in very curved head skulls that may change a lot, aesthetics, in terms of pushing the skin. And if it's ischemia with bigger devices, you may face problems with skin as long as it will push the skin or create some pressure on the skin. That does not happen with bone bridge because you can bend the antenna, you can put everywhere.
Mario.
I hate comparison, but you oblige me.
Okay, it's my fault.
It's just fault. It's not the same to put this over the bone that introduced under the bone. The stability is completely different. The microtrauma of in children, especially in my country, all the child and the women play football, soccer. It's impossible. If you had the prosthesis inside the bone, it's perfect. Outside, I don't know.
Okay, well, time is pushing, so let's move to the next presentation, and then we can keep with the discussion where we left it now. So, for the next presentation, our virtual travel, I hope this time doesn't take us back to the past, but just to a different country, is moving to Valencia in Spain. And we are in Valencia just to meet Dr. Carlos de Paula. Carlos is the senior attending physician in the otology, auditory implants, and lateral skull-based unit within the ENT and head and neck surgery service at La Fe University Hospital in Valencia. He is also a member of the associate teaching staff in the Department of Surgery at the University of Valencia, Spain. And his expertise includes otologic, surgery, pediatric, and adult audiology, hearing implants, as well as head and neck surgery. Hearing is honored to have Carlos as one of today's panelists, and he will deal with a very appealing topic, which is epitheses and bone conduction implants, simultaneous surgery.
Thank you, Javier. First of all, thank you to the hearing group for inviting me to this fantastic roundtable. I'm going to talk about the combination of epiplating systems and bone bridge. Like Javier said, I work in Valencia. Valencia is close to the Mediterranean Sea and is the third country of Spain in population. Why bone bridge in atresia? Because what we were talking about is anatomical compliance. We can put the implant in all the places, all the skull, mastoid, retrosigmoid, supratemporal, and regardless, we have the same hearing gain regardless of the location of the implant. So this is a characteristic that we think is the best of this implant. And the surgical time is very short. We are talking about 35 or 60 minutes, and we have a big flexibility, so we can adapt the implant to the skull surface. And why we do a combined aesthetic and functional treatment? This was a picture of like 2 years ago when I was walking in British Museum in London, and I saw the statue of Amenhotep III, and you can see on the left side, he doesn't have pinna, and maybe he will have middle ear malformations. So I thought that if we could do in one surgery, we could put the pinna and we could put the implant, one surgery, one step, and maybe those children who come of another surgeries like Nagata or problems with another reconstruction surgery will have a simple solution and just 1 or 2 days of stay in the hospital. So we designed a mask. In the mask you can see in the back part, you can see the holes of the screws of the bone bridge, and then you can see in the pinna part the holes of the epitheses. So we designed 2 masks. One mask is for working in the office, and the other mask is for working in the surgery room. It's very important because so we can get this perfect symmetry, so we cannot go 1 millimeter or 2 millimeters down, because if you go, then you are going to see it in the patient. So we perform a CT. Why a CT? Because with the CT we can design the mask, we can know what's the perfect position for the bone bridge, and we can know before the surgery if some of the structures like dura or vessels are going to be or can be affected with the surgery. So I think CT is just for security and for design the mask. This is some case. We use the Autoplan program of MEDEL to know the deepness before the surgery. And here is like you see here, how we use a triangle muscle flap of upper base in all cases, even in cochlear implants. In some of these cases, we have to remove a previous implant, like I heard before, sophono. All of us, we are removing all the sophonos of previous years. So this was one of the first cases. Here you see this girl is 12 years old with albinism. She had some Nagata surgeries before with infection. So what we do is we do the surgery, and in 2 weeks we take out we remove the staples and stitches, and in 1 month, if all is okay, we activate the implant. In 3 months, we put the epitheses, like you see, she needs to wear sunglasses all day because of the albinism. And here I have one result 1 year after the surgery. This is another case with a sophono before surgery. Here you see how we are working with the mask, first in the office and then in the surgery room, how we take out or how we remove cartilage remnants and we preserve the skin for closing. It's very important in this case to remove cartilage remnants, and how we see in the imaging the results 1 month and when we activate the implant, and 3 months after surgery. And in some cases, like this one, we have very bad a lot of scars because of a surgery of distraction of the mandible, and some of them are very complicated. But if you remove of the cartilage remnants and you leave a very plain surface, you don't have problem. How you see that here in the picture, the flexibility of the implant, and how we get the results in 3 months in a peer-robin patient. So as conclusion, we can say that, as I said, bone bridge demonstrates safety and excellent functional results in pediatric population. And this excellent anatomical adaptability allows aesthetic and functional reconstruction of pediatric patients in ear malformation in, as I said, in a single intervention. Thank you very much, and thank you for your time.
Thank you very much. So, the use of epitheses is better than any other solution. What about cartilage, Medpor, other options?
No, this is not a fight against Medpor, or some of these patients came for previous surgeries with Nagatas, and even some of them with Medpor surgeries of distraction. So this is just another way of doing it in just one surgery with no pain, 2 days of stay in the hospital. So we think but this is not an alternative. It's another way of.
And I mean, we were dealing this morning with the issues, skin issues concerning bajas and percutaneous devices. This is a percutaneous device. Do you have skin issues with that?
We didn't have, but we have like 10 cases, so we have to wait. But our first 10 cases, we didn't have problem with the skin. We didn't have problems.
And what's the long term?
We started with this like 3 years ago.
3 years ago. Okay, we have a question from the audience. I think Professor Hagen wants to come into into sound. I mean, it's not in the chat. Can we have Professor Hagen? Rudolf? No? Okay. Okay, we have a question from here. Just keep it. Try to get Professor Hagen in the audio, and we have a question from Italy.
Yeah, thanks a lot. Very nice, interesting system together with the transcutaneous device. My experience is with percutaneous device because I've done 4 cases during the year, since 10 years. Simultaneous in cases like this. They all had previous reconstruction, Nagata type, and I did simultaneous the BA at that time with the surgery, taking off all the ugly ears. The first patient, he had 19 surgeries before. So just to say that many of those patients went in revisions. And so this is very important because finally they get a very nice solution. Aesthetically, it's very difficult to distinguish it from a regular ear. So it's nice to see this approach also with the transcutaneous device because it applies and is a single surgery, as I did with the percutaneous one. And actually in the first patients I had any problems of skin.
Well, I totally agree that the aesthetical result with epitheses is much better than any other way. I mean, in my opinion, it's not a matter of debate. Do we have Professor Hagen?
Hi.
Yes.
Can you hear me?
Yeah, go ahead, Rudolf. Go ahead.
Hi. I have two questions. The first was to Mario. I'm a little astonished in the small children, if you have this little skull, to insert a bone bridge in a 2-year-old child, especially if you say you insert these bone bridges in cases of chronic otitis media, where you have no aeration in the mastoid. So this is a first question to Mario and the other to the last speaker. You know, all these children suffer a lot before they enter the school. So it would be ideal to have this combined surgery before they enter the school. Had you any case before they entered the school, reconstruction of both the pinna and the hearing?
Okay, thank you very much, Rudolf. As you know, Professor Hagen is the president of the hearing group. So, Mario, go ahead.
Hi, Rudolf. Regarding the first question, our patients under 5, all of these are implanted in mastoid position, mastoid regular approach. Therefore, we see in the CT scan with autoplan. We see the enough space to do this. In supratemporal line approach, the problem is the cortex of the bone. Usually it's not enough, and in its posterior approach, the convex of the skull base is very remarkable. Therefore, we use only this technique under 5 in mastoid position.
Okay, Carlos, can you answer the question?
Yes, in our hands, the indications are the same that with the bone bridge. So if we have children with 5, 6, 7 years, we can do the surgery and then to change the epitheses, because the screws, you don't have to move the screws, and the epitheses, you can change it. In our system, they can change every 2 years. Every 2 years, they gave them the 2 epitheses. So we can start 5 years, and they can go changing the epitheses with the age.
Okay, Carlos, one last question, quick answer. As I mentioned before, bilateral is an issue, especially in malformations. Can you do this, bilateral simultaneous one stage, or you don't do it, or?
We didn't do it, but I think it's not impossible to do it. We can.
You didn't do it? You had the chance, but you didn't do it? You do it 2 stages?
I didn't do it because I didn't have the chance. But
okay.
if I...
And you will do it? Will you do it? Single stage?
I think we'll do it, yes.
Okay. Okay, thank you very much. We keep with the discussion further on, but right now it's time to continue our trip, our virtual trip to, this time, Brazil, to Campinas. And we are here, he's more his age than you. We're here to meet Professor Castillo. Arthur is the professor at the Faculty of Medical Sciences and a member of the Ethics Research Committee at the Unicamp in Campinas. And he's focused on surgery of hearing rehabilitation and cochlear implantation, basically. Hearing Group is delighted to have Arthur Castillo as one of our active members, and he will deal today with bone conduction implants in cholesteatoma?
Thank you very much. Thank you, Peter. Thank you, Mario. Thank you, all friends. Thank you, Thomas, for having me at this meeting. I'll talk a little bit about much more protocol that we started thinking like a year and a half ago when we were in Campinas for a temporal bone lab. And we're talking about having patients with cholesteatoma rehabilitated with a bone bridge, for example. And then I'm going to present you the protocol. So far, we have the clearance from the ethics committee. So I guess it's time to get started with this protocol. So as you know, we have a problem, I don't know in your country, but in South America, we still have some patients with chronic otitis media, most of them with cholesteatoma, or a large number of patients with cholesteatoma. And having the surgery to remove the cholesteatoma may even worse the hearing levels. So the idea is to have those patients rehabilitated with a kind of bone conduction device in this protocol, the bone bridge, for patients with canal wall down surgery. So the idea is first to eradicate the cholesteatoma and then to implant a bone conduction device to rehabilitate hearing. We can do that in one step, can do that in two steps. We're trying this protocol to do in one step in order to avoid two surgeries, two anesthesias. But the problem is that we don't know it's not very easy to one step if we do the surgery to remove the cholesteatoma to implant the device if the hearing level is still the same. But the idea is to have those patients under surgery and rehabilitated one step. So in this case, I'm showing you not a patient with canal wall down, but a patient with the cholesteatoma and implanted device, retrosigmoid or a medial fossa implant, not inside of the mastoid, because all those patients will be canal wall down. So it would be a prospective study, single subjects to design, with a controlling by itself. So the four centers that agreed to be part of the studies is ours, Professors Gavilan, Mario, and Skarzinski Center in Poland. So this protocol is for adult patients, 18 years of age or older, suffering from cholesteatoma with canal wall down technique, bilateral conductive or mixed hearing loss, respecting, of course, the bone bridge indication. Of course, the patients need to be in accordance to do the surgery, sign the ethics committee disclosure protocol, and need to be native speakers. So in terms of anatomy, those patients should have erosion of the atticus and lateral wall in the CT scan. Of course, it's extensive cholesteatoma that are needed to put the canal wall down. And of course, if you do a radical or modified radical surgery, discontinue the ossicular chain. Exclusion criteria, retrocochlear or central auditory disorders, of course, of neurosensorial hearing loss, and physical, psychological, or emotional disorders that would interfere with the ability to perform tests, because you will see you have some tests after the surgery, before and after that. So of course, subjects that do not meet the criteria for having implanted a bone conduction device or fluctuating hearing loss. So before surgery, we're imagining between 30 and 40 patients, maybe 10 patients for each center. Informed consent should be signed, audiogram, of course, the threshold hearing unaided and aided with hearing loss, the speech tests in noise and in quiet. Probably we're going to use the hint test. It's not confirmed yet if other centers can do that. And after, the patients should fill the abbreviated profile of hearing aid benefit and the speech and spatial qualities of hearing scale. Then we go for the surgery. And after the surgery, we redo all the tests and even more tests after that. After the surgery, at the date of activation, we do again the threshold unaided and aided, speech test in noise and quiet, and now again the APAB and the SL skill. So this is the idea, to have in different steps the evaluation of the patient. So pre-op, as I have mentioned, we have done those tests. We're going to do those tests. The surgeon with canal wall down, at the same time implanting the device, pre-implant activation, the day of activation, we do those tests again. After we activate, we redo those tests, And 3, 6, and 12 months after surgery, we do the same test, but we also include on the follow-up testing, 3, 6, and 12 months, the HUI, the vision, hearing, and speech ambulation, dexterity, emotion. It's another test, it's the hearing utility index that evaluates all the abilities of the patient. So with that, we can cover not only the hearing abilities of the patient, but all the abilities that may be related with hearing and hearing loss. And the idea is to, as we mentioned before with Mario's presentation, in Brazil, I guess in Argentina, we don't have all clearance for all kind of disease. In Brazil, we cannot do bone conductive devices for cholesteatoma right now, but with this study, we give some information for the government, for the Ministry of Health of each country, to include as a formal indication rehabilitation with bone conduction devices for patients with chronic otitis media, in this case with cholesteatoma, which right now it's a gap for treatment. We don't have a very, very good treatment for those patients. So the idea is to start this protocol. As I said, we have the clearance of the ethics committee so far. We need to get together to start doing this kind of protocol. Thank you very much.
Thank you, Arthur. Okay, so what you said, what you told us, means that there are some situations where we don't think about conventional reconstruction and we move directly to bone conduction devices. Am I right?
You're right, and you agree with that when you...
Yeah, no, yes. But right now I'm asking you.
Yes, I guess it's it's maybe more expensive way to do things, but I guess it's much easier and the results are more feasible. The chance of achieving a good hearing result with the bone conductive device is better when compared with reconstruction, because reconstruction depends on the skills of the surgeon. And I guess in the next years, there will not be many surgeons dedicated to the ossicular chain reconstruction, which is quite difficult surgery, quite challenging.
Okay, so there are two issues. Number one is it's not for every case that we still have conventional reconstruction.
Correct.
So what are the limits? When do we know that this is not going to work? Because we know that some of these patients will not work. This is why we are doing this. Yeah. What are the key factors telling you this is not going to work the old way?
I guess extensive cholesteatoma by itself are challenging in terms of reconstruction. Most of them, they don't have part or totally part of the ossicular chain. So anatomy prior to surgery should be a factor. The problem, I guess, is during the surgery for cholesteatoma removal, if you manipulate very much the stapes, for example, or if the stape's not there, or you need to remove the cholesteatoma very close to the oval window, round window, that may pose a challenge in terms of this patient will not work because of the residual hearing would be not enough for. I guess that's it. In terms of reconstruction, the ossicular chain, before surgery, you can have some hints about the way you can do that, but okay. I don't know the answer.
Concerning money, and I will ask then Mario, concerning money, I was this morning at a session, I was chairing a session where a lady from Saudi Arabia, from your group, Rahman, she presented a study, cost-effective study, showing that the bone conduction device was cheaper than going back and back and back and back and doing more operations. So money is an issue, but maybe depending on the way you look at it, is an issue in favor, not against. So, Mario, I know you have problems with that.
I have some complaints about it. Money is not my problem. My problem is the infection of the patient. This is the topic, in my opinion, because the limits that you refer, Arthur, are true. Because in one time, cholesteatoma is a Pandora box. In a moment, open, and it's impossible to control, blah, blah, blah. And you know, you can put the bone bridge in posterior inferior position, in middle fossa or stellar approach, but the connection through the bone is real. It's not isolated. Therefore, my complaint is due to in young children. I can divide. In young children, I prefer 2 times, 3 times, classical reconstruction, blah, blah, blah. But in adults, probably, yes, it's a good option 1 time.
And infection, why? I mean, you're putting the
Yeah,
bone
you're
bridge here,
far away. Yeah.
and you have the problem here.
Yes.
So if you have the appendicitis, you cannot put the bone bridge because you have an infection.
Okay, but you know that many patients with cholesteatoma has, for example, meningitis. For example, we are talking in our countries, not in US or in Austria. I'm talking in countries where the culture of no control post-operatorily, it's very usual. This is my complaint.
Georg, Austria.
You know, we have to separate the problems. First of all, we have to control the disease in chronic years. This is one part of the story. And the other part of the story is the functional reconstruction. And I think that the functional reconstruction is much easier and more constantly reliable with a bone conduction hearing aid. Not hearing aid, a bone conduction implant, with a transcutaneous one. And I think in the future we will have much more instruments with that to have better implants. Sorry to provoke a little bit. But when we see now the available bone conduction implants, they are quite a bit bulky for children, especially for small children. And I was wondering a little bit, because I like to use this stellar approach or the supratemporal line approach also for smaller children, and you can place even the now available bone conduction implants very nicely in the supratemporal line. And they're safe there, and you're away from the pathology. So, to make a long story short, we need to have smaller implants to treat the patients in a much easier way. And of course, independently from that, we need to eradicate the pathology. With a cannonball down or cannonball up procedure, whatever. But when I look to those patients who got multiple classical surgeries, more than 90% of those classical surgeries will fail in the long run. After 5 years, they have bad audiological results. And this is the truth, and nobody likes to hear the truth, basically.
So this is why this may work. So I agree with you. The problem, the guilty people are the engineers. I mean, they need to design better, smaller devices. But going back to your position is to control the disease and recover function. If we still do that, like we're doing now, we start recovering function 15 years when we just throw the towel away and start thinking that we need something else. Because controlling the disease, talking about cholesteatoma, as Mario was saying, is a very difficult issue right now. So we can keep doing something to control the disease, but we have the hearing preserved already. Arthur.
Well, I don't see that as a challenge. I mean, removing the cholesteatoma, be sure that the disease is removed. Kind of all down patient first. If you do that all right, it probably remove everything. Big meatoplasty, and need to remember that protocol is for adults, not for children, and then we can go for that. I mean, the main point is only in one step. If you do that in one step, to know if the residual hearing is enough. I mean, that's the only point. I guess it's really challenging in terms of doing that in those patients, and I agree totally. Bone conduction devices are much resolutive compared to reconstruction.
Mario,
why I ask you?
No, I'm
No. Sorry. To the engineer. Why don't you do the mastectomy canal wall down first time, and after that, 5 days, 7 days after, put the adhere? Enough. My friend.
Well, it's not the same power. No.
Sorry, I know.
You need a perfect.
We publish a comparison between bone bridge and adhere. It's 10 decibels. My God.
Well,
okay.
You need a perfect bone conduction, less than 20 dBs. Otherwise, you cannot use it.
But Mario, you have
not so many. We'll have a lot of questions. Great.
But Mario, the acceptance of adhere over half a year is going down. So people are getting sick of.
Sorry, my question is for the panel. If you've done a canal wall down, you've got problems with the canal wall down the rest of their life. And especially, I live on a small island, there are a lot of sailors. Why can't we go one step ahead and close the cavity? Blind sac closure.
Wow, we're getting in troubles. Close the cavity, Arthur.
What is the function of a canal wall down?
Now the
when
problem
you
is
already
not the function, it's the problem of closing the cavity.
Yeah, but closing the cavity for patients with cholesteatoma and canal wall down, I don't think it's a good idea because we need to control afterwards. As you said, it's a disease forever. Those patients are candidates anyway in this protocol for canal wall down. Regular mastodectomy, canal wall down, meatoplasty, and those regular stuff. And what we're putting together is the rehabilitation at the same time. But I did think open cavity is good.
Those patients who had a canal wall down, they keep coming back after 20 years.
Yep.
They got an implant.
Yep.
Now I closed those completely, and they're happy.
But there is no contact in between the cavity and the implant. No. So why close the cavity? And not to control the cavity.
Infection. It causes infection after infection after infection because...
If
But
you
the
have
problem of closing the cavity is that you can get in serious trouble.
You cannot-
like a wet.
But you cannot control the cavity if you close it. If you close it, that's a problem, I guess, in my opinion. Yeah,
that's a problem. Go ahead.
Hello, Gaurav Chowdhury from the UK. I had two questions. One was, considering the recurrence rate of cholesteatoma and the practice of using MRI DWI imaging to monitor for recurrence, I'm just interested in what the panel does about what's the earliest after primary cholesteatoma surgery that you would consider bone conduction implants, considering their the artifact on MRI scan. That was the first question. And the second question was, in terms of quality of hearing, we've got lots of objective metrics on how good these devices are, but going from the principle that air conduction hearing quality, natural hearing, is better than bone conduction, surely that means that we should give patients a chance with a ossiculoplasty before jumping straight to BCI.
Who wants to answer?
But don't you agree that to reconstruct in a canal wall down cavity with no ossicular chain is not very easy as to achieve the natural hearing? So that's why probably we're doing this protocol to compare and be one step, one surgery, and that's all. I guess that's why.
We have a question over there. The microphone, please. Go ahead.
Thank you very much. This is really interesting. Now that we've been speaking a lot about canal wall up, canal wall down, and the direct site on it, but for hearing results, does not the quality and the substance of the stapes become a more relevant factor whether you decide to implant or not? Because if we have stapes, we have a higher chance of passive reconstruction instead of when we have a proper radical cavity with no stapes where the torps don't really cut the mustard.
Yep.
Who's going to answer many questions?
I can say that when you do the surgery of a cholesteatoma, you have two problems. The first problem is the recurrence, and the second problem usually is the hearing loss you are going to have with the cholesteatoma. So in our cases, like he said, we just wait 2 years before the bone bridge. But why? Because we perform an MRI at 2 years, and if the MRI is clean, we go to the bone bridge implant. But I understand the proposal of him, because if you have a patient, an adult, not a children, with the without the stapes, with the oval window that you think it's okay, the round window it's okay, and you know that you are going to get transmission, hearing loss because of the surgery, and you are in an open cavity, you can do a bone bridge at the same time, but in a retrosigmoid or in temporal fossa, never mastoid, never.
Well, I agree, and yes, last question before we move to the next
Okay,
block.
This is a long topic because there are many possibilities. I mean, we have experience because in the past, for instance, we used the vibrant sound bridge simultaneous in attic cholesteatoma with the mixed hearing loss, so with the high frequency sloping course, so in which anyway we needed an hearing aid after surgery because the patient did not have normal hearing. In those cases, we put simultaneous vibrant sound bridge in the round window if there was no ossicular change at the patient at the middle. We didn't publish it, but we have the cases to look back and see how they go. I think and then many other cases, always with mixed hearing loss, in which in the time of a revision, because we had a middle ear ventilation problem. So we know from the first surgery retractions in canal wall down or canal wall up. So middle ear is not working, and in the revision, then I put a retrosigmoid implant, bone conduction implant. If the hearing is in a range, I can put a bone conduction implant. If not, I will put a round window vibrant sound bridge. So it's very difficult. The other issue about the blind sac closure and obliteration, I use a lot. You know, those patients with open cavities that even if don't have a recurrence, but have the cavity and have problems with the cavity and have an hearing loss, then I will solve it simultaneously, do a subtotal petrosectomy with obliteration and put an implant simultaneously. We have a lot of those.
Okay.
Actually, it would be nice to publish and
okay.
make the difference.
I'm sorry to interrupt you, but the plane is leaving. We are now making our last jump. It's very close to here. From here, well, we were not. We were in Campinas. From Campinas to St. Polten. And we're in St. Polten to meet our host, Professor Georg Sprinzel. He's the professor of otolaryngology and head and neck surgery, as well as the head of the Department of Otolaryngology and Head and Neck Surgery at St. Polten University Hospital here in Austria. He focuses on stapes surgery, surgery of active middle ear implants and cochlear implantation, and also on neurotologic and oncologic skull-base surgery. We are really grateful to have Professor Sprinzel as one of our renowned hearing experts and as today's panelist. You know, Professor Sprinzel was really busy with this great event, and we skipped him from the need to prepare a presentation. So this is going to be an open discussion with him, and we are going to take it from where we are coming. We are going to take it from the cholesteatoma, and he will deal more with active middle ear implants. So Georg is right now in a worldwide contest. Is the idea of vibrant sound bridge the same of active middle ear implants, or do we have something else?
The idea of vibrant sound bridge is the same of active middle?
Right now. Is there any other?
Well, so I think in the long run, I believe in the vibrant sound bridge, and also I believe in the further development of the device. I think we have a very special need with that device. It should be fully implantable one day.
Good.
And this would open up the field for a complete different setting of patients. This is one part of the story. The other part of the story, and we addressed this in the talks before, of course we are dealing also with patients which are having a chronic disease. And I think when we deal with those patients with a chronic disease, with cholesteatomas, I believe that in the long run, for those patients, bone conduction hearing devices will be a very good tool to help them with the functional problems, not with the disease itself. But you can easily said implant those patients, give them back the functional hearing, and independent treat the disease. Yeah.
So I think this is, I mean, I mentioned that this morning. In my hands, SoundBridge is a wonderful tool for patients with cholesteatoma after several operations, no recurrence, where you can close the ear, make a subtotal petrosectomy, as we were saying before, and put a SoundBridge, because those patients recover hearing on the deaf ear, and at the same time stop having draining ears or problems with water or whatever. So why it is not so popular? I mean, why it's so seldom used, Sombridge?
I will emphasize again, a chronic ear will remain a chronic ear lifelong. It's a lifelong disease. And even if you then use the vibrant sound bridge, even if you close the cavity and you do the most perfect subtotal petrosectomy with the closure external auditory canal, after 20 years you can have some really funny stories, you know. So you can have recurrences even after 20 years. And we should keep that in mind. So independently, the vibrant sound bridge is a very good tool for patients with a mild to moderate hearing loss and can help those patients on a very stable way for 20 years. So I implanted my father-in-law 18 years ago.
That was a punishment?
And he was and he used his bilateral implants for 18 years. Unfortunately, he passed away at the age of 95. So the vibrant sound bridge is a stable solution for some candidates. And I think when we have this tool in our hands as a fully implantable tool, it will open up because there's a huge market for that. Independently from that, we need to treat our patients with cholesteatoma, with chronic ear diseases, and so on. And for those patients, I think we need to find something which is, I think, a little bit more robust than the vibrant sound bridge.
So what about asymmetrical hearing losses and bone conductions or middle ear implants?
Very good question. So first of all, asymmetrical hearing losses and middle ear implants, it works. We have some patients which are really benefiting from that. But of course, you need to find the right candidates for that. So it's not they're not growing on the tree so much. So those are the pearls in otology, I would say. They can benefit from that very heavily. Yes.
Yeah. Mario, what about Sombridge, vibrant Sombridge? Vibrant Sombridge.
I agree with Georg that the vibrant Sombridge is a very good prosthesis. It's an air conduction prosthesis that the sound is better than any bone conduction prosthesis. Therefore, I love vibrant Sombridge. But in the case of cholesteatoma, for example, it's difficult to do it because the only control, if you have a subtotal petrosectomy after removal of cholesteatoma, is MRI.
Diffusion MRI.
Yes, and it's impossible to control. This is my complaint, nothing else. But vibrant in the other pathologies is very good.
Arthur.
I guess sound bridge is a very nice device, powerful device. We have some regulation restrictions in my country to have it. But I guess also the surgery is not the same. You need more expertise. You need to do surgery better to do vibrant sound bridge. And I don't see a problem with MRI because we usually don't do MRI, as the other fellow asked, in controls of cholesteatoma in this case. I guess if you achieve a very well controlled cavity, and that's not very difficult to have it, I guess, kind of all down, really down, up to the level of the facial nerve, and no cortical angles, and explore the tip of the mastoid, and good myotoplasty, you achieve a good control and can use any device, I guess. So we don't use that in Brazil because we don't have the regulation and the reimbursement for use it, but it's a very, very nice device.
Okay, I think we are going back to the discussion before because that was more appealing. You don't use MRI with an open cavity because you don't need an open cavity. Do you all agree? Arthur, Carlos?
So if you have an open cavity, you can control the disease easily.
You don't need MRI.
Clinically, yeah.
So you can have an open cavity, good, well done, down to level of facial nerve, good myotoplasty, and you can use a bone conduction device. That was the point before. So why not moving to that? Because the idea that was here in the discussion before is that we don't do that because we never did it before. But progress means doing things that we never did before.
Yes, so but you have an audiological limitation with the bone conduction devices.
Yes, of course, as long as bone conduction is above 35 degrees, 40 degrees, 40 dBs, you can do it.
that's it. But when you have to treat a patient with a cholesteatoma, many times, of course, those patients are suffering also from inner ear hearing loss.
But for those keeping a good bone conduction and within the limits of the indication of a bone conduction device, doing that and focusing on both ideas you mentioned before, removal of the disease and recovery of function, you keep on removing the disease, but you give the patient function at the same day of the operation. So, why not?
Well, the problem is when you put in a bone conduction device and you don't control the disease, you will run someday into trouble. And
with the bone conduction device here?
Yeah, of course.
Why?
Because the disease will progress in the middle ear. So when you
but
you have no control over the patient, of course you can give him the bone conduction device, but
you mean if you have no control of the patient?
Yes, but no control of the disease. So some patients are more or less indolent, and they're happy, they can hear, everything is fine. Maybe they have a discharging ear, but they never will come back into your office or anybody's office. And then after 2 or 3 years, well, maybe you can have a complication of a chronic otitis media with bad outcome.
Not doing something because the patient is going to be happy and not come back to you.
No. I didn't say that that we shouldn't do nothing, but of course there's also a trade-off. So you can implant those patients, but we have to control them. So you need to get them under control.
What do you think, Arthur?
It's a lot of ifs. I guess it's a problem. That's why we're doing a protocol. But I guess the problem is that you never know what's going to happen with the patient. So never knowing doesn't matter doing nothing. So I prefer to do something and follow the patient. Of course, in this study, the patients will sign they're going to follow up, this kind of stuff, probably. I guess we can reach a good control of the disease. And if it happens of the hearing level to go down, I guess most of them, if they go down immediately after surgery, not years after. It may happen, but it's not what we see usually. So I prefer to go further with the protocol.
Mario, you need?
We need a double control, randomized.
Well, that was the idea of doing it was not double control.
Yes, because the option that said Georg is very... I agree with the Georg. In general, because my complaint with cholesteatoma is the unpredictable behavior of the cholesteatoma. This is the real, the recurrence, the 80% of the recurrence in between the two years later the first surgery, and this is the problem.
But this is 2 years, and the problem with Georg was 20 years.
2 years with adhere, 2 years, nothing else. Then remove. That here is very difficult to remove. Imagine a sticker, okay? And after that, do the exam and do the second look and the reconstruction and compare with the other.
Well, but the second look, I mean, the problem with the second look is that was very popular in the 80s. But we stopped doing that. I mean, because patients didn't come back for the second look, and you left disease thinking that you were going to be removed, you will be able to remove that on the second look, and then patients didn't come back for the second look, and an approach that was very popular in the 80s stopped. We stopped doing second looks. Arthur?
Yeah, I guess if you do, again, canal down, radical, or close to that canal down cavity, well done myoplasty. If you have recurrence, it will not be surgery. You can deal that clinically most of the time. The problem is that what we see is that most of those surgeries that we have recurrence is not a kind of well down, or not totally, or it's something in between. It's a failure of the surgery, I guess, not well done surgery. I'm not saying in general, but that's what we see.
So I think I mean, it's not a bad idea. I mean, I don't know what. Okay, good. Let's ask the audience. What do you think about doing a canal wall down, a good canal wall down approach for a cholesteatoma, a large and extensive cholesteatoma, leaving the cavity open? You can control that. You don't need MRI. You don't need a CT. You just have a look with a microscope or even an otoscope and do a procedure for hearing rehabilitation like a bone conduction device. Who wants to go for that in selected cases? Okay. The microphone.
Is the choice should be decided by surgeon or a patient?
Say it again.
Is this choice should be decided by patient or surgeon?
The patients always have to decide their approach. I mean, patients have the right to decide what they want, but they will decide depending on what you tell them. Okay. So this is a double-edged weapon.
The reason I ask is those people who are in water sports or very close to the sea, they hate it to go with the cavity into the water, and they do not want the cavity.
Okay. Okay.
I agree with my colleague. I'm going to spin back the question. You asked the question, there were very few hands. If you perform a subtotal petrosectomy, there's a lot of literature that the chance of recidivism is really low. And even if you have one, you don't need to do anything. You can just follow it even with CT scan. So maybe you should ask the question, who would do subtotal with bone bridge?
The question is asked.
Who
wants to do a subtotal petrosectomy? You mean immediately after the removal?
Yes, so in a severe cholesteatoma, whether you have the option of a complete radical cavity, open cavity with meatoplasty without ossicular. So the proposal you made, so no possibility for ossicular reconstruction, so bone conduction device will be the best option. So would you do an open cavity with meatoplasty, or would you do subtotal and then add at the same time a bone conduction device?
Who wants to do a subtotal petrosectomy and close the ear immediately after removing the cholesteatoma? That's not what I'm sorry to tell you that you're the only one. I don't think any of us would like to do that. Not me. All the subtotal petrosectomies I've done for fibrous Stonebridge have been in patients after years of recurrent draining ear, not cholesteatoma, no recurrent cholesteatoma, no skin at all for years. And those are the cases where I close the ear canal, not in patients immediately after removing the cholesteatoma. I don't think you will find here many, well, actually, you didn't find anyone.
No, I'm meaning these cases, not primary cholesteatoma.
No, so not immediately after removing cholesteatoma.
It's the same discussion as my colleague. So why open it completely up if you can just close it down?
But you have to close it down later on, years after that, when you are sure that there's no recurrence. And Georg mentioned that you can have that even 20 years after the operation. Well, I think, is there any other question? Yes, one last question, and we have to close because...
Just a small comment to add that I think I quite like the idea of my colleague who's speaking about adhere, just because we've talked about radical mastectomy, nice open meatoplasty, but unfortunately, certainly the world that I'm experiencing, you see a hybrid, as you said. Some cavities have been inadequately drilled, some cavities have been partially or completely obliterated. So I'm finding that the traditional teaching that a modified radical mastectomy, you can see the disease, is not what I'm seeing. Sometimes a patient has quite a nice looking cavity, but may have some ongoing symptoms, and when you go in or you do a DWI, you see buried disease. So, last thing is, why not use a behind-the-ear hearing aid after your primary surgery? And if it comes to it that they need a bone conduction, then by that time they've had a couple of years, or use an adhere and then go for the implant. I'm sure the companies wouldn't like that, but...
Who wants to answer? I mean, this is what we've been doing for the last 40 years.
Yeah, that's what we have done, yes. I guess the results with the hearing aids or even adhere is not the same. It's the power, it's not the same, of course. It's like a middle term result that we have after that. And if you have to wait to recurrence, in these cases, you have to wait the whole life.
Years.
That's the problem, because you never know when it's going to recur. So I think there are two different things, rehabilitation and removing the cholesteatoma or having the healing of the otitis media are something that goes together and they not interfere each other. That's the way of this protocol was meant. I don't know if it's correct. Let's try.
May we have the microphone here? Professor Hager, tell us something. What do you think? You didn't say anything, and I see your face disagreeing with most of what we said.
Well, I'm very thankful to the panelists and with their experience, and I think the beauty here is that we treat our patient with all different options, and we are going to be soon like ophthalmologists. We offer them laser, lenses, eyeglasses, and let the patient choose by himself. And I think for our point of view here, some of us as a surgeon are interested more in ossiculoplasty and cleaning the cavities, and some of us are interested in the hearing aid and seeing a good result. So I think the beauty here is the variations. And I think we need to keep this variation to keep our discussion and the beauty of the otology. Otherwise, if we make rules and fix it, definitely one day we're going to regret.
This is the Arabic wisdom. Okay, well, I don't think there are more questions here, so we are almost out of time. And well, I hope you all here and those at home have enjoyed our discussion today. I'm not sure whether you learned something or not, because I'm not sure whether I learned something or I forgot something I knew before. But we cover some pretty hot topics that leave many open questions. I mean, I'm sure we didn't solve anything, and the conclusion of Rahman was very realistic, and we have to explore this in the future. I just want to thank you all, the panelists, people here, people at home, for your attention and participation. And before closing, just let me mention some basic final comments. You can find in this webpage, our webpage, you can find the hearing tools. The hearing tools, we have the hearing preservation calculator, which is an Excel page where you can just go there, put the figures of the audiogram of your patient and have an idea of hearing preservation according to the work that we publish at the hearing led by Professor Skarczynski and Arthur Lawrence. You have the counseling platform, hearing counseling platform, and the fitting tool for electroacoustic stimulation. You also will find there the quality standards. The hearing group has published a large list of quality standards for children, adults, and older adults, and they include a comprehensive approach to every situation that includes general rehabilitation and minimal outcome measurements. It's just worth taking a look at the quality standards we have published as the group. The Boost, the Hearing Boost, is our educational platform, which is basically a learning management system. You can find here all the courses certified by the hearing. They're all recorded. You can access them just by going to the webpage and going for the Hearing Boost. And I just to remind you, excuse me, that you can get accreditation for this roundtable, those at home and those here in the audience. Gracias, Mario. And you have to go to CPD, the webpage, go to the boost at hearing.com, and you can get international CPD points free for the first 30, and takes up to 6 weeks to receive them. We are a very active group, an extremely active group this year, and these are some of the conferences we've been, or we are going to be, oh my goodness. We've recently been in Chennai, we are here in Vienna, we went to Frankfurt and Hanover. We went also to Rostock for a stapedectomy, otosclerosis, stapes surgery conference. We've been to Béziers, to Colombier. Recently, we have been to Kerala, Vienna, Kuala Lumpur, and Naples will come in the future. And finally, send us your doubts, your questions, and any other thing you need to our webpage, and we will be more than happy to answer any idea or comment that you will send us. And with this, I will just finish the presentation, and thank you for your attention.